discussing on this video just nausea, vomiting, anorexia, and some esophageal disorders. Now, anorexia is not the disease, the mental health disease, anorexia nervosa. Anorexia nervosa is the mental health disorder where there's some emotional imbalances there that leads to anorexia. Anorexia in and of itself just means a lack of appetite. So that is what the word in context means here, is lack of appetite. In severe cases, can lead to malnutrition. It is controlled by the hypothalamus. It is affected by odor, stress, drugs, fear. Psychosocial illnesses can also lead to anorexia. With glucogenesis, glycogen is storage converted to glucose for usage. So here the patients lack some glycogen, so they don't have a lot of glycogen storage that they can use, so therefore they'll be weak. With anorexia, the patient will often not have hunger pains. They will not be hungry. They may be nauseous. They may have signs of vitamin deficiencies for a lack of nutritional intake, and weight loss is apparent. Diagnostic tests we would want to do is mainly to check how well their body is doing in relation to what the anorexia has done to them nutritional deficit wise. So low hemoglobin and red blood cell count is expected. Low proteins like albumin and total protein levels will be low from a lack of eating meat and high protein foods. Cardiac dysrhythmias are very common to have an elevated U wave or some other cardiac arrhythmia from a potassium deficiency from a lack of nutrition. The management depends on the cause of the anorexia. So sometimes it's caused by illness. Maybe they have cancer or suffering depression or something along those lines. So they'll want to treat the cause of the anorexia. Give supplemental high caloric diet. So that is your Boost, your Ensure, that sort of thing to help give more nutrition that way. TPN is kind of the last resort. That's IV nutrition, parental nutrition. Total parental nutrition is what TPN stands for. It's given IV at home or in the hospital. It is given as fats and lipids and nutritional content that's given IV. And psychological support or counseling may be necessary. Nursing management is to take a good history of the patient, assess their bowel and bladder habits. So maybe they're having diarrhea or maybe they're having constipation depending on how they're eating. Or maybe they're not even having bowel movement. So that's something you want to investigate. Determine what their food preferences are. With anorexia or people who are losing weight, you'll give them foods that they like to eat. So you feed them what they like to eat. If they like to eat Doritos and chocolate pudding, and then that's, by golly, what you give them to eat. Anything is better than nothing. So you want to give them, you want to start off with the foods that they like and then start to build a nutritional plan. Daily weights is important, and then a strict INO. Nausea and vomiting is common as a nurse to see. It can be from lots of different things. What we want to assess for is a loss of appetite with it, signs of dehydration. Do your skin turgor look at their fluid intake? Do they complain of thirst? Or do they have little or no urine output? So we'll want to assess their urine output if they are having nausea, vomiting. If they have severe nausea, vomiting, you may see low levels of serum sodium and chloride. So we would want to replace that with normal saline IV fluids if they are having dehydration from the nausea, vomiting. A high hematocrit just indicates dehydration. So when you're taking a sample of blood, and let's say I'm going to draw a blood jar here. Okay, so there's a flask, one there, one here. Okay, so let's say we have blood. You know, we have blood here in both of them. So we have blood in both of these tubes, and let's say we're drawing a hematocrit level. I'm going to make the green the hematocrit cells. Okay, so we're going to have cells. So say we have a regular hematocrit level on the left here. And then let's say on the right that, let's say on the right side, we say it's not normal. We've lost some of the fluid, okay? So you have the fluid here, and it's lower than normal. And all of those cells got squished. So when you draw your sample, it looks like there's way more than what there is if it had been drawn at a regular fluid volume balance. So high hematocrit indicates dehydration. So for nursing management, we want to get a good history. We want to see if we need to change their oral medicines. If they're vomiting, we can't give oral medicine. So we have to find alternate routes. So say I have a patient on postpartum and she's vomiting from, nausea, the hormone shifting and stuff, and she's just sick. So we want to change her pain pills to maybe IV medication or maybe some rectal Zofran or something like that, rectal phenergan. So we'll have to figure out if we need different routes for medications. Okay, in order to help alleviate nausea and vomiting, we will require or request that our patients eat small, frequent meals, drink slow, have dry, salty foods helps like saltine crackers. Cold foods and drinks are better than warm foods and drinks, so cold things help. The other things we can do is take a cool, wet rag, a damp rag, so make it really cold and put it on the patient's forehead or on the back of the neck actually helps too. For post-op nausea, sniffing an alcohol pad seems to help. If they're vomiting, we want to know what color the vomitus is because that will tell us what else is going on. If it's coffee ground, that's an indicator of bleeding. Maroon color is bleeding. Green is just bile, and that's normal. So we want to know what it looks like. We'll do I-nose on people who have nausea, vomiting, and then frequent oral care and peri-care. Oral cancer is usually the result of smoking, tobacco, and alcohol use. Okay, the patient will complain of dysphagia, difficulty swallowing. They may have a lesion or a lump within the mouth or a tongue. The first person who will find oral cancer is usually the dentist, because when the dentist examines your mouth, if you've been to the dentist recently, the dentist will take a piece of gauze and hold your tongue and then really inspect your whole mouth, and they're looking for oral cancer or other lesions in the mouth. So they're usually the first ones to find it. The patient may have pain, soreness, and bleeding. They may lose their taste, or they may have leukoplakia, which is white patches in the mouth. If any sort of cancer becomes very meaty and bleedy, it bleeds a lot. So cancer places is very delicate tissue that's eat up with cancer cells, and it bleeds. So if there is a significant blood loss, they will want to replace the blood loss if there is hemorrhaging. Patients may have radiation and chemo or surgery. It may spread to the neck and lymph nodes, so doing an assessment on the neck and the lymph nodes would be appropriate. They may require tracheostomy or a peg tube because they will not be able to swallow, and it may impair their breathing if the cancer is large enough to block the airway. For nursing care, we'll want to take care of the oral area because a lot of mouth breathing may be going on and it may smell from the cancer. We want to take care of that. Make sure the airway stays patent. Trach peg care if it's needed. Speech therapy may be needed. The patient is fresh out of surgery, Always lay the patient's head on the side so that the fluid can drain out of their mouth and not into the back of their throat, impeding their airway. Keep the patient in PO until you have orders for PO fluids. Antiemetics for nausea, vomiting. So anytime you have an oral or a nasal or a throat surgery, it's absolutely no coughing, no sucking on straws, no vomiting. So we want to prevent all of those things. Keep the head of the bed up, provide emotional family support and pain management for oral cancer. Okay, GERD is gastroesophageal reflux disease, very common. It is a lower esophageal sphincter problem. It's weak and it lets gastric fluids seep back up into the esophagus, which is the reflux part. It can be caused by hiatal hernia. It can be caused by overuse of NSAIDs or other medications that may weaken the lower esophageal sphincter. Obesity is one of the causes because it puts pressure on the sphincter, or certain foods like spicy foods. On the assessment, the patient may complain dyspepsia, that's burping, atypical chest pain, so sometimes it feels like they're having a heart attack. Regurgitation, they'll complain that it occurs after eating and can last 20 minutes to 2 hours. So we'll look at some nursing interventions for that in a minute. Pain is relieved by water, and sitting up helps, and antacids. If the reflux is severe enough, it can cause tooth erosion and hoarseness. And then if it continues, it can actually lead to laryngeal cancer as well. So we're going to do an EGD to observe the esophagus and the stomach and to see what's going on. If the GERD is really severe, it can become Barrett's esophagus. The Barrett's esophagus is a precancerous cells that are there that are going to lead to cancer if it's not treated soon. So Barrett's esophagus is like the worst kind of GERD. They could do a 24-hour pH monitor. So that is a little device that is inserted during an EGD, and it relays information to a box outside of the patient's body, and it lasts for 24 hours. And they take a food diary, and it tells the physician when their pH in their esophagus is high or low, and they can determine if it's related to their sleeping patterns, their eating habits, or exercise, or whatever it is they're doing. Manometry is available for sphincter pressure, so that's like an NG tube, and it goes down just like that, but it's actually a measuring device, and the patient swallows against the device, and it measures the pressure in the esophagus, and they can use that to help determine weak spots in the esophagus. They can do a barium swallow to see if there's any regurgitation there. Or they can have a fundoplication, which is surgery, or a Nissen. So sometimes we call it a Nissen fundoplication, where they basically will go in and wrap it with a, they'll tighten that lower esophageal sphincter surgically and make it really tight so that nothing can come up. Now, post-op fundoplication, they may have an abdominal distension and nausea because they're unable to belch or vomit. So patients should avoid carbonated drinks because of the bloating that may occur. So with a Nissen or fundoplication, abdominal distension and nausea may happen because they cannot belch or vomit, and we need to make sure they know that. Now for nursing management, we'll get a history of their diet and use of meds. Diet change should be eat smaller meals, avoid pepper, coffee, alcohol, chocolate, peppermint, licorice, citrus, caffeine, and high-fat foods. Did you write that down? Write this down. So they can't have anything good. So they can't have pepper, coffee, oh my goodness, coffee, alcohol, chocolate, peppermint, licorice, citrus, caffeine, high-fat foods. Okay, that's just crazy. But yeah, these are the things that make GERD worse or can lead to GERD. So they have to change their diet. So these are things they need to avoid. Losing weight is something we should help encourage the patient to do. They should sleep on their right side, and that will help digestion better. And if they elevate the head of the bed, that will help to prevent aspiration. They need to take their medications as scheduled. The next one is is just a recap of what I just said. So there are things that you should write down right here. So with this NCLEX question, a nurse is caring for a client with gastroesophageal reflux disease. For which of the following instructions should the nurse reinforce teaching? Limit caffeine intake to 2 cups of coffee per day. Remain upright for 2 hours after eating. Follow a low-protein diet. Take medications with milk to decrease irritation. The correct answer is B. Remain in the upright position for 2 hours after eating. So this is the correct answer. We should tell our patients that they should stay in an upright position for 2 hours after they eat. It will help digestion and help prevent the reflux. If they wouldn't lay down right after they ate, then they would just have the reflux and it would be worse. A client has a serious complication of chronic acid entering the esophagus over many years. What is this called? Okay, so it's another form of GERD. Chronic acid entering for a long period of time, and the answer is 4, Barrett's esophagus. Okay, this is a picture of a diverticulum, and a diverticulum is a pouch or a weakening of the esophageal wall, and it forms this pouch here. This is a barium swallow picture that I'm drawing on. And this part is this is open here. This is what this looks like here. This is the pouch. Not good. This is the esophagus on the left. This dark part here is an ulcer and it's bleeding. Okay. Nobody really knows why it happens, but the signs and symptoms are a foul breath. Oh my gosh, the breath is very bad breath. And we have to tell the clients that that smell is not going to go away, unfortunately, because there's food stuck in here, you know, and it's not going anywhere, and it just decays. So you basically have rotten food here in your diverticulum esophagus, and it's just staying there. They may hear gurgling sounds in the upper chest. They may have difficulty swallowing because things don't really go down straight, so it probably feels funny going down. Diet therapy would be bland, soft, and semi-soft liquid foods. And the only thing they can really do is a surgical excision of it. They just have to take it out. A hiatal hernia, there's a couple different kinds. I wouldn't say that's really important to know the different kinds of hernias. It's just a diaphragm defect and lets some of the stomach protrude through. So some of the stomach will protrude through the diaphragm, and it causes GERD and heartburn, belching or pain after eating. A lot of people have one and don't even realize they have one. So sometimes it's mild and sometimes it's severe. You can see it on a barium swallow. They can try to stretch and narrow the esophagus endoscopically if scarring happens, but it's not really that significant here. What we can do as nurses is to reduce the symptoms of the reflux. If they have fundoplication or a Nissen or something, we can provide small frequent meals and avoid straining. So here is the picture of the hiatal hernia. This part of the stomach is coming up through the diaphragm. On the last slide here is esophageal cancer. So this is a picture of the esophagus. And this right here is the cancer. This is the cancer. This part is cancerous. This part over here is cancerous. See how it's really shiny and mean looking? It bleeds. So if I touched it with anything, it would just start to bleed. This one is it can be from squamous cell carcinoma, related to alcohol abuse, smoking, tobacco, overuse of nitrates, which is found in like hot dogs and stuff like that, processed meats, and then GERD can cause it. So if Barrett's esophagus isn't treated early enough, it can turn into this esophageal cancer. Patient will have difficulty swallowing, of course. They may feel a lump in their throat. Do you see the lumps up here? That would feel really strange trying to swallow over that. Hoarseness from the GERD that's going to be happening there. Halitosis is the really bad breath because cancer stinks. Weight loss, because cancer causes weight loss because of all of the carbohydrate and glycogen that it needs to reproduce itself. So you'll have some weight loss there. Regurgitation, hiccups are common, and odonophagia, difficulty speaking. With management, they'll have an EGD and a biopsy to confirm. So you'll need a biopsy of the area to confirm the cancer. They may have chemotherapy and radiation. They can also put in stents, which is something that's temporarily done so that they can still continue to swallow without having to get a peg tube. And the stent will hold makes the hole bigger. So the stent will come in and it will be a circular item, like a mesh tube, and it will be inserted and it will hold the esophagus open so that the patient can swallow. So that's something that they can do interventionally. And then they can possibly come in here with an EGD scope and some tools and snip some of this cancer out of the way and burn it, and then continue with chemo and radiation for the rest that they can't get. For nursing management, get daily weights, provide the patient with a soft diet list, pain management, prepare for the gastrostomy. Like I said, they can get the esophageal stent first to hopefully avoid the gastrostomy tube or the peg tube, G tube, whatever you want to call it, and aspiration precautions because of the nature of where this disease is.